Welcome again. My name is Diana Arias with the Community Technical Assistance Center at the NYU Silver School of Social Work's McSilver Institute. Today's offering, When Children and Adolescents Do Not Go to School, Terminology and Assessment with Dr. Morrow is obviously a hot topic right now. Students missing school is not a new topic, but we are hearing more and more that this is happening at an increased rates. So for today's webinar, you will be provided with some foundational information around this topic, especially focusing on exploring the reasoning behind the school refusal behavior so that you can best support youth. Before we get started, I do want to orient folks so that you know how to participate in today's events. So by now, you're very familiar with Zoom, but just in case, you have been placed on mute upon joining, just so that folks are able to listen to the presentation. If you do come across any technical issues during today's event, please chat to the CTEC host who will be able to support you. If you would like to activate closed captions, you certainly have the opportunity to do that as well. You will also have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature. But in order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions or comments at any point in time during the presentation, and we'll hold off on those till the end of the presentation. And at this point, it is my pleasure to pass it along to Dr. Christian Morrow, Associate Professor and Director of the Psychosocial Treatment Clinic at the Department of Psychiatry and Behavioral Sciences at Duke Child and Family Study Center. Again, thank you all for joining us. And Dr. Morrow, welcome.
Thank you, Diana. And it's great to be here. I grew up on Long Island, New York. So it's great to be back home, even though I'm in the basement in my home office. So again, my name's Chris Morrow. I'm a clinical psychologist. I've been at Duke University for over 20 years. And my clinical practice is working with kids and adolescents. I supervise and train a lot of different students in different professions. And this is just a very interesting topic that I started to get very interested in right before the pandemic, and a colleague and I wrote a chapter about this because we were seeing such an increase. And then with COVID and the boom of online education, it really exploded. So I'm happy to be here. Let's start with a chat and see, what do you think are the factors that contribute to missed school attendance in young people? So I will look at the chat and I'm seeing a lot of anxiety. I'm seeing a lot of mental health reasons, bullying, housing, transportation, so socioeconomic issues, parent stress, so many issues, falling behind, family challenges, the COVID, homelessness, exhaustion. Thank you so much for these excellent contributions. And I think what we can see, learning disabilities, difficult peer relationships, basically what we can see from the chat, and thank you to all of you for addressing this, is this is a very complex issue, and it has many, many different factors that contribute to missing school. So thank you for that. I'll be revisiting the chat as we continue. But here's the outline we have for today. We're going to talk a little bit about schooling and then this COVID factor that really amplified things. We'll then revisit some of the historical context and look at the terms and definitions for kids who miss school. We'll look at what kinds of kids and what kind of characteristics of youth who do miss school. And then we're going to get into an evidence-based assessment approach where we are looking at understanding the functions of school refusal behavior. And then at the very end, we'll talk about how do we look at the treatment for some of these children as we apply components from cognitive behavioral therapy. So as I mentioned, unfortunately, I'm not up in New York with all of you. I'm here in North Carolina. And the COVID factor just really changed how our world works in terms of schooling and work, and for education. So before the pandemic, less than 10% of children were schooled from home. But during the pandemic, over 90% of households use some sort of distance learning. And as we move forward, we are probably going to see some version of a hybrid where, just like this webinar, there's going to be a lot of like education that is provided online. Whereas I see we have well over 300 participants, and the access to these educational schooling issues is the access is so much wider than in person. And so there's tons of benefits. And then there's also some things that we'll talk about that might be problematic. If we look at the digital age, and I'm dating myself here, but when I was a child in the 1980s, video games became very popular. And I remember asking for Atari for Christmas one year. And unfortunately, I got Pong. So I'm not exactly sure what that was about. Maybe I wasn't as good as I thought I was. But then I also remember in college in the 90s, in my senior year, I remember I was in a computer lab because we did not have our own computers. Someone said, wow, I'm communicating with someone in California right now. It's called email. And I was very skeptical and looked over, and sure enough, someone was communicating through email. As we entered the 2000s, things became more portable in terms of laptops, personal desk assistants. I don't know if you remember those. They were basically like, calendars. And then Wi-Fi really transformed technology. And then in 2007 and 2008, I think these two things really have had the biggest influence on our lives. The beginning of the iPhone, and then Facebook started a year later in social media. By 2010s, almost everyone had a smartphone and used tablets. We saw the wearables and smart watches. And then obviously in the pandemic, video conferencing like this became the norm. And where are we headed? Well, I think AI and ChatGPT and virtual reality are all things that will continue to progress and impact education and learning for students. So absenteeism has always been a challenge for children going to school. And before the pandemic, the data showed that about 5% of kids miss school every day for a variety of reasons. And then we had about 10 to 15% of students miss nearly a month every year. And these are the kids that had more problematic attendance. And the research, there's been a long history of research showing that kids who missed school had a much poorer prognosis in many different outcomes. It would lead to dropout, would lead to greater risk of substance use, mental illness, delinquency, and then economic and occupational problems in adulthood. Post-pandemic, we saw lots of interesting challenges as kids started to re-enter school. There were weeks where they had to quarantine and then having to go back and falling behind and feeling anxious about where they were. We saw lots of fears of getting sick among not only children, but all kinds of teachers and administration and being in the front lines. We saw the rates of mental health problems was on the increase before the pandemic. And then the pandemic exacerbated a lot of these. And so you're seeing lots of kids who are struggling with mental health. The access to online education has increased. And so as I mentioned earlier, a lot of schools are doing hybrid models. And so what you're seeing is a lot of kids are not worried about missing school because they feel like they can just catch up online. What we did see is about a third of kids were chronically absent after a return to in-person learning. And on the average day of last year's school, close to 10% were absent and 25% were chronically absent. And what we mean by that were was that they missed at least 10% of school for the entire year. This next slide shows that there's just a sharp rise in school absences. And as you can see, we highlighted New York, that there was a 33% increase. And this is very similar to where I am in North Carolina, where there's a 31% increase. But basically, you see in these largest states in our country, where the highest populated states, it ranged from about a quarter to almost 40%. And you can see that there are different ranges there. So what I'd like to do now is go back and look at the historical context for how we understood kids missing school. Thankfully, in our country, compulsory education started to become very, very popular in our society in the 19th century. There were beliefs that an educated society benefits all, and the decreasing of child labor and putting them out of the workforce and into schools was very important. However, with this, there was always the challenge of absenteeism and children missing school. And this has been studied for well over 100 years. And who studied it, it ranges from educators to psychologists to medical professionals like psychiatrists to social workers, sociologists, juvenile justice, and a range of mental health professionals. Some of the first terms that were used about 100 years ago was truancy. And this referred to kids that were willful and without parental knowledge not going to school. As folks realized, that wasn't all of the kids they weren't all willful and defiant. There were a lot of kids who had emotional issues. And so this is where psychiatry and psychology entered the terminology and introduced neurotic delinquency, which later became psychoneurotic truancy, sort of a combination of recognizing that kids who miss school and who are truant had some psychological problems. Unfortunately, as is much of the history of psychology and psychiatry, a lot of the blame there fell on the parents, and particularly mothers, due to our unfortunate sort of sexist history of psychiatry and psychology. But really, there was this two thoughts where, and this is interesting because when I do consultations with school, it's still very much this kind of either or thinking, where it's either willful delinquent behavior like truancy, or it's a complex mental illness where, and we get stuck in, is it one or the other, rather than recognizing it's usually a combination of many, many things. Other terms that became more common was school phobia, a fear of going to school, and then separation anxiety. So school phobia was coined in the 1940s. This is where we would see acute child anxiety, a lot of somatic symptoms, which I'll go into later, some hypochondriasis. And again, as I mentioned, a lot of the writings at this time was focused on the mother's neuroses rather than the individual child factors or any kind of systemic factors that you all mentioned in the chat. Separation anxiety disorder became a recognizable condition with persistent and reluctance or refusal to go to school because of a fear of separation. And to this day, that is a criteria for the disorder of separation anxiety disorder. Some other terms that are important to understand is, there's school dropout. This is when an adolescent's decision to leave school on their own. In North Carolina, it's 16 years old, and in New York, it's 17. It's about 5% nationally. However, overall in our country, school dropout is declining due to the increase in alternative programs that give kids in this late adolescence some other options to end their schooling. Other term is school withdrawal. This is when kids will withdraw from school and it is supported by the parents. This example could be homeschooling, which is increasing significantly across our country. It was trending upward before the pandemic, but now since the pandemic and since the advent of all of the technology that we just mentioned, it is really on the rise. Other kids might withdraw from school due to severe illness or medical conditions. On this slide, you can see that there's been really interesting shifts in student enrollment by school type and region in the last 5 years in New York State. It shows that while homeschooling and charter school enrollment has increased in every region, you'll also see that private school enrollment has declined in regions, all the regions except the mid-Hudson area. So thank you to the team up in Diana and her team for doing a lot of the research and helping me with some of the statistics for New York State. But this is a very consistent national trend that we're seeing, and I think a lot of it has to do with our political climate, where there is less investment in public education, traditional public education, and more investment in alternative ways such as charter schools, homeschooling as well. Other terms to be familiar with is school exclusion, and this is mostly based on a school-based decision, usually to deal with difficult behavior problems. So suspension or expulsion are areas where kids will be removed from school due to their issues in terms of suspension and expulsion. And unfortunately, as we know, the data does not support a lot of this as a helpful issue for addressing school problematic behavior. Two of the terms that have been more recent and have gained more of a presence in the research is school refusal. And I'm going to go over how we talk about school refusal. And then I have a couple of references that really even makes it more broad in terms of school attendance problems. Regardless of the term, there's been significant problems in the research because there's been so much confusion regarding like what terms do we use and how do we study these phenomenon when we don't have a common language. So unfortunately, a lot of these terms have not been good at being reliable, communicating among different providers, whether mental health, educational, or medical. There hasn't been a lot of sound measures. And also it's been really hard to predict what is a individual child's prognosis and how do we treat it? And then what is the outcome? So a term that has been proposed, and I'm a big fan and admirer of the work of Christopher Kearney, who has done probably the most research in the United States on this area. He developed the term with colleagues called school refusal and came up with a definition. Kids who are refusing school miss at least 25% of total school for at least 2 weeks. They have severe difficulty attending school for these 2 weeks, and there's significant interference in the child and family life. Now, very often the interference might be in the child's life, but as we'll get to case examples, the interference is often felt in the family's life, as there has to be much accommodation around their work schedules and their daily routines when children do not go to school. The third part of the definition is these absences of at least 10 days during any 15-week period. And that equates to about 25% of school missed. So again, this was the definition proposed about 20 years ago, and it has been used for research for the last 20 years. The advantages to the school refusal term is it defines what is problematic absenteeism. It gives us a common terminology. It has assisted communication among the different professionals, and it's led to some really important research on kids who refuse school. This term has also led to the development of an assessment approach, which I will review with you all later. And because of this assessment approach, it can then guide our interventions so that we can accurately target them with specific strategies depending on what subtype the child exhibits when they refuse school. Well, how common is this? It's very common. It's very common, as I mentioned earlier, before the pandemic, and then clearly during and after the pandemic. As you saw, like the returning after the pandemic was about a third, and about a third will exhibit some school refusal at some point in their developmental trajectory of education. The incidence in clinics, mental health clinics, so if you're in any mental health clinic and look at a sample, about 10 to 15% show signs of school refusal, but I would say this is significantly increased given our newer data. What does remain consistent is we do see key periods of time where kids will exhibit school refusal. The most obvious is when kids start kindergarten. So for kids that are not engaged in any kind of like preschool or other kind of daycare and are not used to and are staying in home settings, that transition to school can be very hard around 5 or 6 years old. The other time we see significant challenges is around the beginning of high school. But the most significant and highest rates are during middle school, between ages 10 and 13. Regardless of the age, the heterogeneity is the norm for school refusal. Just like you all mentioned in the chat, there are so many different reasons, some internal to the child, anxiety being a huge one that we're going to talk about, that are systemic within the family, like parenting challenges or socioeconomic, and then more greater systemic issues like community violence, homelessness, socioeconomic and cultural issues as well. A recent article that I also recommend is this one. This will be in your slides. And this is a researcher outside of the US who looks at the differentiation between different school problems, why and how. And for more interesting resources regarding the terminology we use, and there might be a trend moving away from school refusal to more school attendance problems, I would guide you to this article. Okay, let's move on now to look at what are some of the characteristics of youth who miss school. I'm in an academic medical center, and so I'm in a department of psychiatry and behavioral sciences, but we are also linked to primary care and pediatrics. And we see lots of kids in primary care and pediatric settings who miss school, who report significant somatic symptoms. In the autonomic system, they report dizziness or chest pains, a lot of headaches. In the gastrointestinal systems, we see lots of children with stomach pain, nausea, vomiting, diarrhea, and then muscular issues with back pain, joint pain. Regardless of the somatic symptoms, we will often see severe misbehaviors in the morning with children who might exhibit tantrums, clinging to parents, aggression, or dawdling, all to serve the purpose of trying to miss school. As I said, I work in an academic medical setting, and very often medically ill children are much more likely to have school refusal than kids without medical conditions. A lot of times schools will often struggle to accommodate these medical issues, such as pain, chronic fatigue, other more severe issues, in individualized education plans. For those of you that work in school-based settings, you know that schools are being asked to do more and more with less and less. As you saw on those slides, looking just at New York State, so much of the funding is being pulled out of traditional public education for other alternative, and this is leading to a really discrepant socioeconomic polarization for kids that need the resources but are not getting them. A lot of times with medically ill children, we'll see this role confusion, where children will often take on a more parentified role if their family member is sick, And so this patient role and student role is often challenging and overwhelming for many, many families. The primary function, and we're going to get to lots of reasons for this, is that children are avoiding something. They are avoiding something at school. And this can range from so many things. It can be objects that they're avoiding. It could be a bus. It might not necessarily be the bus itself, but it could be like the kids on the bus. It could be for a number of reasons. It could be certain things that are very terrifying and scary, like fire alarms. We have kids that we've worked with that are afraid to go on the gym, into the gym and into the playgrounds due to some social concerns. They might be anxious in the hallways or in large classrooms with noise or sensory overload. Kids might be avoiding school for the kids that they see or the people. They could be teachers. Very anxious kids might often complain about mean teachers or people that are mad at them or are abusive in certain way. And this gets very difficult when you get to bullying, because my clinical experience is that the term has become so oftenly used, it's hard to know, to get a good assessment for, is there actual bullying? Is it in person? Is it online? Or is it an overly anxious child who is interpreting typical interpersonal interactions as being overly aggressive and bullying? So this gets to be a real challenge as well. We have kids that avoid performance situations. They may get very anxious during tests or recitals in drama or music or athletic competitions, and have lots of anxiety, maybe speaking or writing in front of others. We also have kids that avoid pain. It could be emotional pain. It could be rejection. It could be anxiety, bodily sensations, or some sort of physical somatic pain that we mentioned earlier. The research on school refusal, when they correlated it with mental health issues, found that there's a wide range of disorders that are associated with kids who refuse school. Many are in the category of what we would call internalizing disorders. These include all of the anxiety disorders, including separation anxiety, generalized anxiety, social anxiety. For adolescents, we see more panic disorder and agoraphobia. We see obsessive compulsive disorder, and then lots of kids, unfortunately, are coping with PTSD for a wide variety of reasons. And then I saw, as was mentioned in the chat, many of you identified some learning issues that kids might have, in addition to more other classic depressive disorders and adjustment disorders. Other common disorders associated with kids who refuse school are externalizing. I like to think of internalizing as kids who make themselves miserable, and externalizing kids who make other people miserable. So parents, teachers, kids with ADHD who are hyperactive and disruptive in the classroom, kids who have oppositional defiant or conduct disorders or substance use. These are kids that are really, really challenging to manage, and a lot of schools do not have the resources. Another population of students that I want to draw special attention to are kids on the autism spectrum. As we know, kids on the autism spectrum are becoming more and more common. Autism rates are increasing significantly across the country. We're getting better at diagnosing it and understanding it. I think that the variety of issues that children with the autism features have are also taxing many of the resources at schools. So are there patterns? Well, when we look at a presentation of a student who refuses school, there are some commonalities. One is, for a young child, we might see a more sudden onset. So again, those children who are just beginning school might have a much higher rate of acute onset, like kids who are starting kindergarten or who are in kindergarten, but then after winter break have trouble re-entering. Older kids often have a more insidious onset, and unfortunately, if it's not addressed, will often have more severe psychopathology and co-occurring problems. So you might see more depression and anxiety, or kids on the spectrum who are developing more significant comorbidity with anxiety and depression as well. There are very often developmental differences regarding the diagnoses. So younger children have separation anxiety. Adolescents have more social anxiety and panic symptoms. School refusal in general is equal among boys and girls. However, among the differences we see is that boys exhibit more externalizing behavior in terms of oppositionality and conduct, and girls will present more with internalizing disorders like anxiety and depression, which is very, very congruent with overall prevalence rates. And then we see it the same in school as well. One way of thinking about it is the factors that may be contributing. And so what are some of the predisposing factors that might contribute to school refusal? Might be their biological predisposition. Are they prone to anxiety? Are they prone to learning disabilities? Does it make it hard? These kids are going to be at increased likelihood to have trouble attending school. Then there might be the precipitating factors, like what is the thing right before the school refusal? Did they fail a couple of classes? Did they fall behind? Is there some conflict in the family? Is there a significant illness in the family? Is there a separation or divorce? Or is there an acute onset of bullying? And then the perpetuating factors, what are the factors that maintain the school refusal? Secondary gain is very common in avoidance. So we're going to talk a lot about, like, sometimes kids will unintentionally get a lot of attention when they miss school, and this can unintentionally reinforce school refusal. And then they might get a lot of positive reinforcement when they are home in terms of gaming, social media, or online factors. When kids refuse school, we see lots of different family constellations and dynamics. For those of you that are more family systems oriented, we might see the enmeshed family, the family that is overprotecting and gets very, very anxious about promoting independence or individuation with their child. And so these are kids that are at higher risk of avoiding school and are a greater likelihood of staying home with the family system and doing schooling at home. You might see a family with high conflict, a lot of hostility, violence, coercive family process where there's a lot of threats and aggressive and violence, and these kids will often not go to school. A detached family where these might be families that are very hard to reach and connect. You might have school social workers that have trouble connecting with detached family, and not until the attendance gets very, very high, or there might be a threat of legal concerns, do detached families become engaged. Very often isolated families who do not have a lot of social support often struggle with kids who refuse school. And then we see kids who refuse school from very healthy families, where there's measures of high cohesion, they're affectionate, they're good problem solvers. And so the punchline is one size doesn't fit all. Kids who refuse school can come from all kinds of different families, and they might have a mix of a lot of these kind of descriptions, and there's many, many factors. Regardless of what family a child comes from, unfortunately, kids who miss school have a poor prognosis. It's kids who, there's some research studies that show that kids who miss most of kindergarten are at highest risk of dropping out in high school. Unfortunately, kids who miss a lot of school are tempted by other risky behaviors, including substance use and self-harm and delinquency. And then as young adults, kids who miss school are at greatest risk for economic problems, problems keeping jobs. And so again, as I mentioned earlier, lots of different research across many different fields of study have continued to show these problems. I mentioned earlier that, I primarily in my clinical practice work with anxious kids. And what led me to write the chapter with my colleague in 2019 about school refusal and kids not going to school was I was seeing a huge uptick in my clinic with kids who were not going to school. And I saw this huge correlation with this generation who we might call iGen or Gen Z, where they were having so much access to technology, whether it be video games or social media, that there was more and more temptation to stay home and less motivation to go to school. One of the authors that I used as a resource and found to be very, very interesting was a book by Jean Twenge, who is a social psychologist who wrote this book right before the pandemic called iGen. She calls it iGen, not because of the iPhone, but because the Gen Z are the kids who have had the internet their entire life. So born around 1995 and older. And the title of her book is Why Today's Superconnected Kids Are Growing Up Less Rebellious, More Tolerant, Less Happy, and Completely Unprepared for Adulthood, and What That Means for the Rest of Us. This is a summary of her chapters. And these are the themes of the kids that we are seeing in this generation. One is they're in no hurry to grow up. In a lot of ways, they're growing up slower. They are getting jobs later. Adolescents are getting their license later. They are going out less. Some good data to show they are having sex at later ages, which is good in terms of STDs and pregnancy rates. However, it speaks to this cultural phenomenon we're seeing where like adolescence might be considered delayed, especially for older folks like myself, where I could not wait to drive, could not wait to get out of the house. And a lot of the reason for this is the internet. Adolescents are spending most of their time texting, gaming, streaming on social media. So much of their social lives are either on their phone in their gaming system and can be done at their home. So kids before the pandemic were trending towards not being in person as much, less quote unquote hanging out. The national trend is that malls are dying due to other kind of socioeconomic and forces like Amazon and online shopping. And there were less places for kids to interact socially. This combined with economic and other systemic issues that led to kids feeling insecure about their own mental health. Ironically, kids that are the most connected electronically are also reporting the highest rates of loneliness and significant increases in anxiety and depression. There's less connection to religious communities. Other generations, millennials would say, well, I'm not religious, but I'm spiritual. Gen Z is saying, I'm not religious nor spiritual. There's a lot more focus on safety and less community. We saw increased rates in suicide and less on homicide. Again, this is overall, there's been changes to that recently, especially with the gun issues in our country. Due to income insecurity and larger portions of the younger generation being in debt, more and more folks are living with their parents after college and during. And again, this might lead to like younger men gaming and sort of feeling that kind of despair that like, I don't know if I can do better than my parents. So why do I, what's the hope there for me? This generation is having sex later, getting married later, having children later, which also leads to some interesting challenges as nutrition and health gets better. Kids are starting puberty earlier, yet they're getting married later and having children later. One of the fastest growing clinics at Duke is our fertility clinic. So these are interesting demographic changes in our culture. Some of the positives of the younger generation is more inclusivity with race, sexuality, and gender, and independent yet distrust with politics. So I'd like to just ask the question, and I'd appreciate it if people use the chat. Are these themes you're seeing in your settings? Does these themes about young adults and adolescents, are they congruent with what you're seeing in your schools and in your clinics? All right, thank you for these. Lots of yes, definitely see these themes. Okay. Thank you for the chats. All right. So let me ask you this, since it seems to be an overwhelmingly yes. If not, are there any differences you're seeing with this generation? I know I have 3 teenagers. I have 19, 16, and 13-year-old, and these are things I'm dealing with not only as in my clinical work, but as a parent. Are there any things that are different that you're seeing? Lacking ambition, motivation, complexity of, yes, vaping and CBD and THC products. I haven't been to New York since it's been legalized, but I'm hearing that's become an interesting phenomenon. Just how prevalent it is. Seeing a lot of these themes. Yep. Some of you are, I'm just reading the chat here now. Thank you. Okay. Yep. So you're seeing a lot of this in terms of getting a job or spending time on, and this is a really good point, Molly, lack of consequences for not attending school. During the COVID era, I didn't mention that, and so thank you for bringing that up. There were so many policies in academic where like kids were not getting held back, or, you know, there were so many exceptions to moving on that I think a lot of like kids moved on, and we're now seeing the lag in terms of like how this really impacted them, you know, academically. And so there were really just, you know, troubles here. Okay. Thank you, David. Good point about sleep. We're seeing lots of problems because of this screen use with children sleeping and having sleep problems. We're seeing them a lot in our clinics. Yes, there's been a significant increase in the LGBTQ community. And unfortunately, these kids are at highest risk for co-occurring mental health problems. And so this is, you know, how do we meet the needs of these young students as well? Issues with intimacy and getting connected. I'll make one quick story. My 16-year-old daughter, she'll kill me that I'm mentioning this, but she's, I think, started to have her first boyfriend or dating. And when I said, "Are you dating him?" she corrected me and said, "No, we're just talking." And I don't know if this is a term that is like popular with teens outside of North Carolina, but I just think it's interesting that the term talking now signifies a level of intimacy and connection that is something that would be sort of normal. But I don't know if I can't keep up with all the chats, but hopefully some people are relating to some of what I'm saying. So thank you for all of these message. Okay. To be fair, talking was used. All right. It means you're not committed. We'll see. We'll see if I get to meet this guy, and we'll see what it means. Situationship. Very good. Okay. I agree that this generation is more open to mental health and more accepting of mental health. Unfortunately, the data is showing that increased attention and awareness isn't leading to better mental health. But again, there's a lot of different factors to that. So yes, thank you for all of these comments. This is excellent, and I really appreciate it. Okay, let me move on as I try to manage our time. Thank you so much, everybody, for these contributions. I can't get to all of them, but I really appreciate your attention and focus. All right, let's get into like some tools that you're gonna leave this webinar with. So really, there's been developed assessment of understanding the functions or what is the purpose of school refusal behavior. When we assess school refusal behavior, we want to get information from as many sources as we can, from teachers, from parents, and we use behavioral rating scales. And the scale that I'm going to introduce you to is the School Refusal Assessment Scale revised version. This was developed by Kearney and colleagues, and it refers to what maintains a child's school refusal behavior and what motivates a child to continue to refuse school. And we use behavioral principles to help us understand how it gets maintained and how it gets, what are the motivations. So let's go through this example, and hopefully, this is a generic example, but I'm hopeful it sounds familiar to a lot of you. We have an 8-year-old boy who cries every morning on the playground before entering school, clings to his mother and complains he doesn't want to get hurt. He was victimized by bullies last year and missed a third of school. This is his first year in a new school. He wants to stay home with his mother. So the playground is the drop-off area for carpool, which is another, I think, generational thing, is more and more families are driving their kids to school. We have, I don't know about you all in New York, but we have like bus driver shortages because they're not getting paid enough. So these are other kind of systemic issues. But basically, if we look at like a functional analysis, you might be familiar with the ABC model. I teach my students the SORC model. The stimuli is it's Monday morning. The parent is stressed out, anxious, getting ready for work and children for school. The child's whiny, upset, misses the bus. It might not be like consciously intentional, but the child knows if I miss the bus, I have a greater likelihood I don't go to school. Mom is like, okay, we're not gonna have this situation again. Like last year, I'm gonna take you to school. We'll go to the drop-off area on the playground, and the child starts to cry. So if we look at the individual organism of the child starts to feel scared, trembles, starts to cry, starts to have a meltdown. Really not much cognitive activity for an 8-year-old, just I want to go home. Maybe there's a what if I get bullied? What if I get hurt? But this child's predisposition is an anxious temperament, poor social skills, and a history of getting victimized. What's going on for the mom? She already feels inadequate. She's embarrassed that this is happening again. She feels like she's a bad parent. Her thoughts are, here we go again. She already herself has an anxious temperament. She's currently depressed and overwhelmed, and she gets very tearful and dysregulated when dealing with her children in the morning. So what is the behavior sequence, the response, or the B? The child cries. The mother says, it's okay. This is a new school. Everything's going to be okay. And the child will probably say, you know what, Mom, you're probably right. Everything will be okay. I'm sorry, that was a little bit of sarcasm. That usually doesn't happen. The child doesn't usually listen to the parent and say, yeah, you're right, Mom, things are going to go better. The child usually will escalate, right? Say, no, please, I don't want to go. I want to go home. Mom tries to stay firm. She's had some mental health counseling. She says, no, you need to go to school. We did this last year and you need to go. So of course, the child like escalates and starts to gag and dry heave. School personnel see this kid and is like, uh-oh, is this kid sick? We don't want to have a vomiting kid in school. Mom is anxious, embarrassed. Before the school resource person comes over, she gets totally uncomfortable and decides to put the child back in the car and goes home. What are the consequences to this? Well, the child does stop crying, calms down, but at home gets to watch a little TV, might get a screen so that mom can do some work. The child doesn't face the anxiety, feels less anxious. We're going to go over this concept of negative reinforcement. Stays home, gets to stay home. Parent has to call in sick or work virtually, watches TV, plays video games, and this also reinforces the behavior. So the mom has to stay home with the child, maybe gets reprimanded at work for having to take a sick day or working from home or not planning ahead. cries, feels more depressed, more self-critical. I must be a horrible parent. I can't believe this is happening again. I'm angry, resentful. It might lead to conflict with the child and other partner. So hopefully this sounds a little bit familiar. I'm looking in the chat and say, it looks like this is something maybe typical or something that you would see. But basically, there's it's so familiar. Thank you, Elaine. There's so many interactions at play. You know, basically, I've learned now as a parent, my God, I thought we can influence our kids so much, but our kids influence us as parents more than we influence them. And it's a bi-directional approach. And so really the child impacts the parent. I'm going to take you back, I apologize, to Psychology 101, but these concepts are very, very important, okay? And one concept I want you to realize is what we call negative reinforcement. People get this wrong all the time, and they think of negative as punishment. But what happens is this concept really, really reinforces school refusal behavior. It's a principle that maintains anxiety and it maintains oppositionality. And I'm going to show you what it looks like. So here we have a child who experiences anxiety, and they then avoid the situation. What happens is the anxiety goes away. So the behavior that preceded it, which is avoidance, gets reinforced. So reinforcement means avoidance goes up because something is removed. And when we say negative, we mean anxiety gets removed. And that's why it's reinforcement. So with parenting, what happens is this avoidance behavior, whatever the behavior is for the kid, dry heaving, tantrums, meltdown, the parent gives in and doesn't set the firm limit of the child staying in school. And what happens is when the parent gives in, the parent experiences relief. The child stops the meltdown, stops the tantrum. So this behavior of giving in gets reinforced by removing this annoying, horrible meltdown behavior. So both of these are reinforced through negative reinforcement. So the school refusal assessment scale, what happens here is what they did, which was brilliant, is they looked at all of the kids who refused school, and they realized that we can categorize kids who refuse school in 4 functions. Okay, here is a link to the School Avoidance Alliance and the School Refusal Assessment Scale, where you can download it for free. So now I'm going to go over what are the 4 main functions of why do kids refuse school. 2 are based on negative reinforcement and 2 are based on positive reinforcement. Function 1 is kids avoid school to avoid negative affect. They avoid objects, situations, anything at school that makes them feel uncomfortable in their body. They feel heart palpitations, they get stomach aches. And when they go to school, they feel these things and it feels so bad that they want to stay home. And when they stay home, these feelings go away so that it gets reinforced by negative reinforcement. That's function 1. Function 2 is they don't want to go to school because they want to escape social situations. These are also reinforced by negative reinforcement. So let's say a kid is dealing with anxiety interacting with kids because they've been used to being home all day and avoiding things like talking to them in real life and just texting. And so they get anxious going to school because of the interaction socially, or maybe it's bullying, or maybe they have high functioning autism, which we're going to get to later. This measure isn't so great at those, but it does really pick up on kids that don't go to school because of social anxiety. So again, they stay home, they don't feel anxious, missing school gets reinforced. There's 2 other functions where kids miss school and it's positively reinforced. One is they stay home because they like the attention from the parent, right? And you've all worked in many environments where negative attention is better than no attention at all. And so lots of kids who want to stay home, they get attention from their parents. It might be yelling and frustration and annoyance, but it's more attention than they're getting when they're at school. So they stay home to get this attention. The fourth is to pursue tangible reinforcement. What this one is when this measure was developed, it was really for kids who are more like truant, who are like out in the mall and out smoking weed and like hanging out on street corners. But what I have found in my clinical work is that these are the kids that are staying home with their screens and they're gaming and they're getting to enjoy so much positive reinforcement of social media and screen time that I think video games and screen time has really sort of overridden the other uses. But the originally, like gangs and drug use and delinquency, is also captured in this function. So again, staying home gets attention, is positively reinforced. Again, a kid isn't thinking consciously, I'm going to stay home so I get attention. Kids are just skilled learners. I tell my supervisees, if a parent or a school or a teacher, someone feels like a kid is manipulative, a good helpful cognitive reframe for that is they're just a skilled learner. They have learned that this behavior works and it gets reinforced. A lot of learning is non-conscious. Positive reinforcement. Another one is function 4, staying home. I get to play video games. I get to be on my phone. It's going to positively reinforce staying home. How do these functions relate to disorders? Well, function 1 is more correlated with no disorder and anxiety and depression. Function 2 is obviously more correlated to social anxiety, but also what you're going to see, interestingly, and not to be a diagnosis nerd, but a lot of research has shown that these oppositional defiant diagnoses are much more related to kids with anxiety than conduct disorder. So again, oppositionality serves the function when kids are having a meltdown. The purpose of the opposition is to avoid something anxiety producing. Okay. And so again, this measure was developed without and before this increased rate in autism. So it doesn't really capture the autism kids, but very often you might see it in function 2. If we look at a developmental trajectory, kids who refuse school will often have an anxious temperament. They'll be inhibited in preschool. They'll have separation anxiety, generalized anxiety when end of grade tests, usually in 3rd grade. If you remember Erik Erikson, industry versus inferiority, kids are comparing themselves a lot. They'll get anxious about their performance. And then in adolescence, mostly we see social anxiety. And then this leads to depression and anxiety disorders in adulthood and panic. So again, the school refusal assessment scale is a great measure to help you understand these functions. It's not like, again, one or the other, but it can help you prioritize which one is the most significant. It has good reliability and validity. You use it in combination with your observations. There are parent and child versions, and I often will give a version to the teacher as well. Okay. So let's go to, looks like I have about 10 to 15 minutes left, and I want to save some time for questions. I think we're doing well, and I appreciate all of the contributions so far. So I'm a cognitive behavioral therapist, and I would like to give you some examples based on using this measure, how we might use cognitive behavioral therapy to address these functions and these issue of school refusal. So cognitive behavioral therapy, for those of you that don't use cognitive behavioral therapy, it often includes psychoeducation. So for example, it might educate parents about school refusal, and it might educate kids about school refusal. It might educate kids about anxiety and about feelings in their body. A huge component is going to be teaching them that a lot of their body sensations can signify things such as anxiety. So a stomach ache doesn't mean you have cancer, or a headache doesn't mean you have a brain tumor, or heart palpitations doesn't mean you're about to have a heart attack. These are your bodily sensations letting you know that you might be anxious about something, and that if you're anxious about something, there are some things you can do to calm yourself down and cope with it. We want to then, after we understand the bodily sensations, we want to help kids understand their self-talk. Again, this is going to be more with 8-year-olds and above. Like in the clinical example, a lot of 8-year-olds and when anyone, even adolescents, when they're in panic mode, they might not have access to a lot of the thoughts. It most just be like, I want to get out of here. I want to get home. I know that's going to reduce my anxiety. But hopefully you can access in a calmer state what some of the what ifs are and the anxious self-talk, and help it with coping self-talk. I do cognitive behavioral therapy trainings, and one of my pet peeves is CBT and cognitive behavioral therapy is not positive self-talk. It is coping self-talk. Positive self-talk could be an actual avoidance, contribute to avoidance strategies. So like if you, like the example I gave with the 8-year-old, if the mom says everything's going to be okay, everything's going to be okay, the 8-year-old might be like, that's bull, mom. I know everything isn't going to be okay. You know, that positive talk doesn't work because it's not true. So that would be an example where that's why, like, sometimes people are like, well, cognitive therapy doesn't work for me, because positive talk can really not be very helpful if it's not realistic. So coping talk might be like, look, I know it'll be tough. It'll be hard in the beginning. It'll be, you'll be anxious, and that's okay. And you can handle it, and it'll get better as you go to school more and more often. So other components of CBT are relaxation training to bring a child's thermometer down from a 8, 9, 10 to a 5, 6, 7. It's not to make it a 0. We don't want to teach kids that they are supposed to never feel anxious. We actually have to teach kids it's okay to feel anxious. It's okay to feel unpleasant. This is another one of my pet peeves, and I'll get back to the iGen stuff, is that because of phones, kids have, and adults, we're in this too, everybody, we have immediate gratification, and we use these things to distract ourselves and avoid ourselves from anything unpleasant. We quickly, you've probably seen this in a therapy or counseling session where a kid will go to technology anytime something unpleasant happens. Okay. So the other main component of cognitive behavioral therapy, in addition to the skills, the emotions and the cognitions, is the behavior. And really what we want to do is gradual exposure, or basically we want kids to be exposed to being in school and cope with their anxiety. We want to help them, practice. We want to get them rewards. And we want, like, for those of you that are in schools or are coordinating with schools, it's really, really important to be aligned with schools to help kids get back into school. Okay, so just some examples. What would this treatment approach look like? If function 1 is the highest on the measure, you might do a lot of therapy that looks at psychoeducation, about bodily sensations, about negative affect, about affect is just affect. It doesn't necessarily have to be negative. It doesn't have to be, it's just your body letting you know. How can you manage these somatic cues? How can you learn to think about it differently? And then how can you desensitize yourself to the school setting and getting back into school? For function 2, escaping social situations, again, school can be a great place to do group therapy, to help them expose themselves to being around other kids, to learn skills like how to talk to kids, how to be assertive, how to identify these things, and again, get back into the school setting. Function 3, with attention to parent and caregiver, there's going to be more of parenting work here, right? You're going to use an evidence-based parenting program, trying to get the parent to be firm, to drop that child off, to reappraise that situation, and with help and support from therapy and schools, that you're being a good parent by setting a limit. It's okay to say no. Redirect your attention when they're doing positive things, not when they're using avoidance strategies. Having rules, having consequences. Again, reinforcing attendance in school and giving attention for that rather than attention at home. For number 4, this is probably, if this function is the highest on your measure, this is going to be the most challenging cases where kids are looking at tangible reinforcement. Again, I do a lot of family therapy, and we try to, work with families to, make sure that home is not more reinforcing than school. Don't be held hostage by their adolescents' screen use and technology. And again, doing family systems work to try to get the kid out of the home environment, making screen use a reinforcer for school attendance rather than school avoidance. Some of the things that lead to success are good psychoeducation, challenging the expectations of the feared outcome, exposure therapy, which means getting back in school, practicing in multiple settings, removing safety behaviors. Compound extinction means removing those things that adults might do to overly accommodate avoidance. Younger kids usually need a more behavioral-based component and lots of parent involvement. And then the biggest challenge I often see is that we are triangulated, and that clinicians and schools are split as enemies from families. And we need to get them on the same page. We need to align school and treatment teams with the family so that we can, have our best chance of getting these kids back into school. Caregivers play a huge role. They often can be consultants and give information to therapists in school. They can collaborate. But unfortunately, in many situations, they're the co-clients. For those of you that do more intensive in-home or family systems work, they might exhibit behaviors that contribute or maintain the anxiety or school refusal. Some of the most common challenges we see is that kids will be rescued by their parents to avoid their own discomfort. And we need to teach parents to extinguish some of these unintentional reinforcers, such as attention, avoidance, and reassurance. I went over this case example earlier, so I'm going to just read this one quickly so we have enough time for questions. This is just a classic 5-year-old, lives with parents and 7-year-old, has always had trouble with separating and going to school, was shy and inhibited as a younger child. During an interview, wouldn't talk to a clinician or counselor, and would whisper to the parent, "You answer the question." The parents noticed a couple of triggers. Going to a funeral might have made the child anxious about death, or transitioning to a new classroom without a best friend. Child would be tearful on the way to school at nap time, complaining that the teachers don't like him and that he missed his parents. The child would settle quickly after school, but they noticed, unfortunately, after Christmas break, which happens a lot, the refusal behavior escalated, wake up crying, beg parents to stay home, have tantrums, and it would get very, very hard. Family history was significant for anxiety and depression and suicide attempts. So parents would engage in a lot of accommodating behavior. With my students, I train them to do a functional analysis. The S would be I drop them off. The O would be lots of anxiety. The R would be like I want to go home, tantrums, and the consequence would be like I bring them home. Let's do a quick little quiz for this child. There are 2 functions that this child would score highest on out of the 4. I'll give you a reminder. Function 1 is to avoid negative affect or emotions. 2 is to avoid social situations. 3 is to get attention from parents. And 4 is to get tangible reinforcement at home, like, gaming or those kinds of things. What is your guess of which of those 4 functions this child would score highest on? Boom, James, you are the big winner. 1 and 3. I do not have a prize for you, but I'm giving you lots of props. Way to go. Excellent. Functions 1 and 3, because they would avoid that anxiety and then get a lot of attention from the parent at home. And then 4 is something you would have to explore also, is what is the child getting when the parent needs that break to do some work? Are they getting screen time? Obviously, those sorts of things. So great job. Thank you for the participation. Positive reinforcement, praise. I hope that helped. Okay. All right. Let's keep going. So an example treatment plan would be based on these functions. I'm going to guide my approach. I'm going to try to work with a child, but also since this child's 5, we're going to have to use a huge behavioral component, and we're going to have to do exposure therapy. So an example like this might be, in the beginning, my mom might stay in the library all day since that's easiest. And then as long as we get the child back in school, then we might gradually graduate to mom stays in the library for the first hour, drops off at classroom at the door. These numbers mean how hard it is. Staying all day and not going to the nurse or going to the principal's office, staying all day. And this might be for an older kid. We see a lot of problems with kids like texting their parents throughout the day. And then we're really trying to decrease that. Maybe like we start with twice a day, maybe then one time, and then staying at school with no communication. I get a lot of questions about how do we force kids to go to school? Well, this is a tricky one. I think the research shows that if the child is refusing school only for attention with little distress or anxiety, this is the kind of situations where you need a parent who's going to be really good at being able to tolerate their child's distress. And you're going to be able to you need a school that's able to handle distress. My experience has been this works best with really seasoned, experienced teachers who do not get fazed or rattled by meltdowns, right? Like the teachers that when see the dry heaving on the playground for our case example would be like, know that that's anxiety and not get shook by it and be like, let's bring this child into the classroom. Let's get them into some special, helper role. And so that they can settle down. Parents have to be willing to take the school and drop off. Sometimes you need one parent to drive and one parent to follow through. But very often parents need to have energy and ability and desire to follow through, because unfortunately what happens with school refusal, it's the same behavioral concept as a slot machine. It could work like 9 days in a row, but if on that 10th day they get to stay home, it's like hitting the jackpot. And if you do it on 6 days and 7 days, it becomes a variable ratio schedule, just like a slot machine, and it's going to reinforce the behavior that led to the avoidance. So when families have hesitation and guilt, it leads to inconsistency. There must be some comfort with being firm and having physical contact, getting into the car. Again, this is with much younger children. You have to reward attendance and you have to be ready for consequences. So again, this is just really, really hard. And it mostly is used with younger children. I will encourage this if it's more acute, meaning like we catch the school refusal early, because I know that the longer they stay out, the harder it's going to be to get them back in. So again, if we revisit the functions, a lot of times we're going to be helping kids cope with stress and escapism for function 1. We're going to be dealing now with online relationships for function 2. And we're seeing a lot of kids with dealing with issues of mastery, control, and having to deal with online stuff in terms of pursuing tangible reinforcement. So, okay, I think I got through everything. With time, here are some great resources and references. Let's go with some questions. I hope, Diana, you've been helping me with these amazing chats and questions.
Yes, absolutely. So thank you so much. First off, there's been a lot of participation, so I appreciate you offering your knowledge. We do have a lot of questions, so I'm going to try to go through as many as we can. Can you speak a little bit more to the teenager, like in high school, who refuses to attend classes? Parents can't physically make them attend.
Right, right.
What would you suggest to folks?
Yeah, like these are the hardest kids. First of all, I do want to say, for all of you who are dealing with this, these are hard cases. These are very challenging cases. These are not easy cases. And so much of it depends on stuff outside of your control, right? For teenagers, a lot of times you do need that sort of multi-systemic wraparound services kind of approach. You have to align with the school, you have to align with the family, you have to try to get the family and the school on the same page, and you have to really get with behavioral contracts. You can't get physical with teenagers. I'll give an example with a teenager one time. The emphasis I talk to parents is you have to make home boring and unpleasant so that they actually want to go back to school. So I had this one where like the parents were doing everything I thought they could. They had taken their phone, taken away the gaming system, and the kid kept staying home. And I was like, wow, this is a tough one. What do you think they're doing? And he's like, this was a single dad, and he's like, I don't know. She sleeps, of course, to avoid. And then when I go to work, I think she's up, but I'm not sure. So after a couple of weeks, sure enough, thankfully, the sibling ratted the kid out, and the student was using a cracked iPad, that the parent didn't know about, and was online and texting and gaming and so on. So it was like really hard, but basically it was like, look, these are not rights. The hardest thing with this generation for teenagers is like they believe technology is a right and not a privilege. And so again, the hardest work is getting families to rethink that and not be held hostage and say like, look, you earn your phone by going to school. You earn your technology by going to school. You go to school, you get these technology privileges. Usually that's the best bet we have for teenagers, but basically it's using, systemic family therapy and behavioral contracts. So that's the best, shortest version I can give, Diana, on that one.
Great, thank you. So let's see. My question is, how do you appeal to students who have no recourse inside the school? A poor school and a poor community offers no motivation. So in terms of how do you help build the motivation for students to attend school in situations like this?
Yeah. I think like another great question, and I probably should have added that into the slide. Like when you're working with teens, you have to do a lot of motivational interviewing. And for those of you, I recommend doing a training on motivational interviewing. It's basically trying to help kids and teens see the pluses and minuses of their behavior. And you're right, for a lot of teens, they do not see, again, I think this Gen Z generation is so in the moment because of immediate gratification that it's hard for them to see the long-term consequences of their behavior. I'm working with one right now. The child just turned 18 and she is in her senior year, and she wants to, leave school. And her parents feel a little bit helpless. Like, besides her phone, she doesn't even drive, but she wants to work and she gets a job, but now she's starting to leave school to go to her job. And, she doesn't go to individual therapy, and all we have right now is family therapy. And we're going to try to enhance the motivational interviewing to say, yeah, I know you want to work. And right now it's great that you want to work and you want to make money. And if you can hang in there for one more semester, you'll have your high school degree in case you want to go to community college, or you want to work your way up with work. And then you want to earn more money. And then I show sort of like the research on like how much money you can make with being a high school dropout versus a high school education. But it's a lot of motivational interviewing. It's hard. Sometimes you definitely need to have a therapist for the teen, and then one for the family, and then the coordinator to coordinate between school. But, the short answer is motivational interviewing, and the long answer is it's not easy.
Great, thank you. And a couple of questions around how to support or work with parents. So for example, for parents that may not have the time because of some of the issues that were mentioned earlier on along the lines of socioeconomic status, if parents are working one or two jobs and don't have the time to really respond to that oppositional response, they may intentionally just give in because there is no time as a resource. How do you maybe suggest working with a parent or family like that?
Yeah, I think like this is, Diana, probably the hardest situation we're dealing with, right? Parents are working multiple jobs. they don't have time to stay home with their kid. They've got to earn an income. They can't be babysitting their child. And then they'll say it's the school's job. I can't help it. You know, the school's I get them to school. A lot of times kids will leave school, and, you know, that's very frustrating for parents. And then a lot of times the schools will blame the parents and say, you know, they can't get their kids here. So again, there's a lot of like, I don't know if people are familiar with the drama triangle. And this is what I was talking about earlier, where schools, families, and therapists often get split. There's like a victim, a persecutor, and a rescuer. And like the worst scenario is when like we're all sort of working against each other. So for those situations, you know, again, like trying to embrace other community resources, churches, YMCA, other group organizations, other, you know, Boys and Girls Club, family members, anything that like can widen the system for support, and trying to create an alliance. Again, easier said than done, but this is very, very hard, but also very, very important. But the thing I would say is that, you know, if you're getting stuck in a drama triangle, get out of it. You know, don't be, the other thing I see mental health clinicians, and actually I'm missing a going away party for one of my colleagues during this lunch, and it's okay, I'm going to see her tomorrow. But she said, Chris, you know, the thing that you've taught me that I really appreciate is I used to write letters to get kids out of school all the time. And now I've learned that that is counterproductive. So much of when I'm working with mental health and health professionals and pediatricians is like, don't write that letter to excuse them. You know, say like, okay, you know, I recommend this approach and re-entry to a school, or like, because once they get on homebound services, my experience is it's incredibly difficult to get them back in.
Great, thank you. So in the interest of time, I'm going to see if we can squeeze in another 2 questions. How do you address intentional misbehavior to prompt suspensions? Our kiddos are often smart enough to know this is a strategy to avoid school.
Yeah. Well, again, I'm not a school personnel, but from what I know, you know, the research on suspensions are pretty long, that they don't really work. And so, I mean, that's why there are other alternatives like in-school suspension, which again, kids then, like the question person might do what it takes to get in-school suspension. But basically the point is, how do we keep kids in school? Try not to get provoked, and use suspension as an escape also for the school, so that they, you know, want to get rid of this kid because it's so problematic. But again, it's going to take more creative approaches, in addition to getting kids hooked in and engaged in school. I've seen some programs where they can do their online work from school, you know, having people check in and check out laptops, other ways so that they don't get provoked into kicking kids out for suspension or expulsion, because, you know, that's sort of like an uphill battle once a kid gets that pattern.
Mm-hmm. And then a very important comment or question that came in. What about teens that state they feel suicidal if they attend school, but sit home and game all the time? Parents feel scared the child will hurt themselves, so they don't press the issue. Any thoughts around that?
Yes, it's common. It happens. Again, we want to take kids seriously. We don't want to dismiss them. We don't want to think of them as purely manipulative. There is probably a percentage of 0 to 100 that does want to die and feels hopeless. However, we can't be held hostage by kids who express suicidality. I'll give a clinical example. I worked with a teen and parents. I said, you know, if a child, I understand you're terrified, you don't want your child to die. If they express suicidality, if they go to school, that doesn't mean that they're like ready for life. That means that they could be suicidal when they leave home, when they get a job, when they go outside of the house. So if a child is suicidal, I will help you come up with a safety plan. And if that means a higher level of care of taking them to the emergency room, and having an inpatient stay, hopefully that's an aversive experience where the kid learns like, okay, I don't want to be in an inpatient unit. Sometimes kids would rather be in an inpatient unit than in school, and then we have other problems. But basically, I try to work with families so that we take that seriously, we address it, we do evidence-based safety planning, but we don't collude with being held hostage by it either.
Great, thank you, Chris. And then just very lastly, in terms of the scales, and we did put the link in, I know a few folks missed the link, it'll be up on the slides. In terms of who uses that, can it be master's level educators? Can it just be, you know, folks that are trying to really get to the core of the reasoning for the school behavior? Are there any recommendations around the scale, the use of the scale?
Yeah, it's a tool. It's not an end-all be-all. It's to guide you, it's to help you. It's a part of your treatment plan, but I think it's the best that we have out there right now for mental health clinicians. And I think it should be, you know, in addition to other assessment measures that are both individual and family when you're working with schools and kids and families.
Great. Thank you so much, Chris. So I know we are at time. Just to remind folks, the recording and the slides will be available on our webpage in the next 2 to 3 business days. It does have the link to the assessment scale. There are a lot of thank yous coming in, Chris. So I think this just really highlights the importance of this issue. On our next slide, I do want to highlight some upcoming events that we have. So I do invite you to join us for these, Understanding Mass Shootings. Then we have 2 others that are really focused around self-stigma for adolescents, for adults and youth and caregivers. And on our on the following slide, we do just want to extend our thank you to our presenter, to you, our audience members. Chris, if you can just forward the slide deck.
This is the last slide I have, upcoming events.
Alrighty, yeah. So we just want to remind folks, thanks, Chris, that we have a pop-up survey that will show up. Again, if you can take the time to fill that out, it does inform our offerings. If you want to learn more about this topic or any other topics, please complete that. On behalf of CTAC, thank you again, Chris, and to our audience members for joining us today. I hope you all have a good rest of the week. Take care, everyone.